too fast.
Sure.
Presenter.
I can't. Uh, Presenting not too fast and on behalf of Medicine 4. So presenting two clinical scenarios of two different patients. Patient R, 32-year-old male, he had come to us with altered sensorium since 5 days, fever for 1 day. He has no known comorbidities. He's a known ethanol consumer since the past 15 years. He's a smoker since the past 10 years. Patient S, 54-year-old male, he has come to us with fever since 1 month, abdominal distension since the past 5 days, loose stool since the past 5 days. He was noted to be poorly nourished. He's a diabetic and a hypertensive. The common thing noted to be with both of these patients is from outside we have seen that both of them had hyponatremia and were treated for the same and referred here for further management. On general examination wise, patient R his respiratory rate was 24 per minute. He was afebrile. His DCS was 14 by 15. He was confused. Patient S, on the other hand, was tachypneic. His BP was 160/90 and he was also tachycardic. His DCS was 15 by 15. On systems examination wise, all systems exam for patient R, there were no findings apart from the fact that he had visual hallucinations. He felt that someone was trying to kill him. One episode of visual hallucinations prior to our admission, after which he had consumed ethanol and he's not had further episodes of hallucinations in the world. Patient S, on the other side, presented to us with no clinical examination findings. Investigation wise, initially hemoglobin was noted to be 12.2, platelet of 298,000, total count of 11,000, a differential of 82, sodium of 129, and potassium of 3.8. His RFT and LFT were noted to be normal with albumin of 2.9. Patient S, on the other hand, had a serum electrolyte had shown hypernatremia of 164 with an RFT of 2.8, creatinine of 2.89. Here in the ward, we had noted that patient R had developed on day 10 since the complaint. He had developed dysphagia and dysphonia and developed left-sided hypertonia, left side upper limb and lower limb. He had developed hemiparesis and hypertonia of upper and lower limb, while patient S, after admission on the second day, had developed severe respiratory distress, developed non-verbalization, and his sensorium also had dropped. Hence, he was shifted to the ICU for further management. In view of sudden drop in sensorium, imaging was done for both of these patients. MRI brain was done for both of the patients.
Even before all of this, otherwise we get lost in the investigation because you're comparing them. Otherwise, we are getting a bit.
Ma'am, patient R, since he was a known ethanol consumer, we were thinking in line of alcohol withdrawal. Patient S, ma'am, if he was actually being evaluated for PO, ma'am, and he's been having on and off fever spikes since the past 1 month. He's been having loose stools and abdominal distension. He was treated in multiple hospitals and referred to us. Outside, he was evaluated as.
What is the diagnosis? Nobody asked a history. What's your diagnosis? No, that way gives us a bit direction. What's your diagnosis for patient? What's your diagnosis for patient? And then we go to the investigation. So just to keep it in line. So diagnosis is a single sentence or a differential.
Diagnosis for patient S would be, ma'am, we didn't reach a diagnosis for that patient.
That time, no, when you saw, there's always a differential. No, they have a clinical diagnosis. No, nobody's asking for each person. Then it becomes clinical diagnosis.
In
did you have a clinical diagnosis at all for this?
Yes, infective colitis, we were thinking, ma'am.
Sure. No, because they are coming in parallel.
Yes, ma'am.
We are assuming they're related to each other somewhere.
Oh, sure.
So that's why we are just kind of making it so that we can follow what you say. And also have an issue with your patient hours diagnosis. You said he's been in the hospital for 10 days.
Yes.
And 10th day he developed confusion, and at that time you consider alcohol withdrawal. So how do you want to match that? Because 10 days somebody's been in the hospital. He thought he took alcohol throughout his hospital stay, or
no?
So that's where it helps. The direction comes out.
Yeah.
Go ahead. I think it's a retrospective thought.
Yes.
It's good to put the neurological findings. You read out a whole host of things.
Oh.
And like the course in the hospital and then coming to the investigation. Good. Anybody else? So basically, you ask me everything your diagnosis. No, it was a bit confusing for us to follow because they're not exactly the same.
Yes.
Investigations also are different, so it's too much data for us. I don't know. So you were talking about something that happened in hospital, right?
Yes, ma'am. Both of the.
Right, in hospital, something happened, which is why you're present here. Right?
Yes, ma'am.
Is it like that?
Both of them were treated outside for hyponatremia. Okay. They've been brought here, and then we've noted these findings.
But they were all noted into which day of?
Patient S, 1 day after. Patient R, almost 10 days after.
Almost 10 days after. That can't be like outside, no? It must be us. No, it's okay. We are not above anything. We can also. All of us can make mistakes. We just want to know whether, when we get to the finishing point.
No,
one patient was already there for 10 days, became altered. One patient was altered at the beginning.
Patient R had received a hyponatremia correction outside, ma'am. His outside, he was corrected overnight from 104 to 124. So.
Okay, and came to us.
Came to.
And developed that hypotonia all in the ward 10 days after coming.
Yes, ma'am.
So that's the worry where, what did we add to it? Because
sure.
Obviously the patient was very good.
Yes.
Go to next.
We'll just continue the presentation, Rithesh.
So what I wanted to try to highlight was osmotic demyelination syndrome.
You can explain the imaging if you want.
Yeah, because that will be more useful for, because people may come like this with an imaging already with them. We also see patients who come in like that, who have a correction, there's a problem.
The typical sign we usually see is in the T2 weighted image is called a Trident sign or omega sign, which will look with a hyperintensity in the middle with peripheral sparing. T1 images may also show hypointensity, but these findings may be usually found almost a week later also. the earliest image which could pick up was a diffusion weighted image, which might show restriction within 24 hours of onset of the deficit. So what is osmotic demyelination syndrome? It is basically characterized by loss of myelin in various parts of the central nervous system due to rapid correction of sodium. Clinical features wise, they usually present after 2 to 6 days after rapid correction of the serum of sodium. Clinical features, they can have confusion, quadriplegia, oculomotor abnormalities, dysphagia, dysarthria, and muscle weakness. The risk factors for ODS, which I wanted to highlight, was chronic hyponatremia, malnutrition, chronic ethanol consumption, hypokalemia, liver transplant, or a chronic liver patient. Less common, hyperglycemia, hemodialysis, prolonged use of diuretics, and primary adrenal insufficiency. So how fast should we be correcting? We should be correcting with 6 to 8 MEQ per liter in any 24-hour period. For higher risk patients, we can correct at a much lower rate for 4 to 6 MEQ per liter in 24-hour period. As per a large cohort done in Mayo Clinic from 2008 to 2012, there were no neurological complications seen in those who were corrected at lesser than 5 MEQ per liter. In those with higher risk, as mentioned earlier, we should increase the frequency of monitoring of sodium. And where should we expect an autocorrection? Whenever we have a thiazide diuretic induced hyponatremia and we are correcting the same, once we stop the thiazide diuretic, we should also keep in mind that there could be an autocorrection. Similarly, in case of an depletional hyponatremia, also on admission of saline, and in patients who are on drugs like desmopressin with discontinuation of the same. Again, mentioning whether there's a role for bolus or an infusion in case of a hyponatremia. This was a multi-center RCT done in Korea from 2016 to 2018. It showed no benefit, for infusion over bolus. Both had similar efficacies, so we can use both of them without any risk for overcorrection. So in case of ODS, what can we do? It is better prevented than treated. There are some case reports showing that relowering of sodium has a role in case we have further corrected. But again, it is more of the role is for supportive care. And a few case reports where IVIG and plasmapheresis have also played a role. Reversible. So what are the options we have? We can 5% dextrose water and desmopressin are the two options we can consider. In case of high risk patients, we should be considering relowering of sodium. But in case of a low risk patient, only if we have overcorrected by 10 to 12 MEQ per liter in 24 hours should we even think of relowering of sodium. In case of our patients, the patient R, we had not further corrected sodium after arrival. He was discharged and he was given physiotherapy and occupational therapy, home-based physiotherapy and occupational therapy. Unfortunately, patient S expired. He was initially started on free water, NG free water. But then his sensorium had worsened and he had developed other complications in the ICU and the family had opted for further withdrawal of supports. Learning point wise, in case of high risk patients, we should correct sodium at a very, very low pace. Those who are at high risk, especially anyone who's coming with a chronic hyponatremia below 105 MEQ per liter, hypokalemia, chronic alcoholics, advanced liver disease, and malnutrition.
Thank you, Ritesh. Do you just want to summarize what your patients came with? What exact difference are you trying to highlight between your two patients?
More than the highlights, I just wanted to show that they were both of high risk patients. One of them was a chronic ethanol consumer. The other was a chronically malnourished patient, actually. So just wanted to be very careful with these patients when we are correcting their sodium.
Sure. Does anyone have any questions?
There's a formula for correction, which is there in Dr. Georgian's book, which you can use for progress correction. I think in general feedback, you know the patients well, so you know what they have. We don't
Yes,
know the patients at all, which is why it's good to have it like that. It's a learning thing and also for us to.
Sure. Yes.
We'll move on to our last presentation.